Okay. Just give me 2 seconds. Hang on. See if that shares. Let's give it a try.
Good afternoon, everybody. Thank you for attending on this very warm day. And I was going to suggest, first of all, that people could take their jackets off, but as I see, everyone has already, because it is so warm. But thank you so much for coming. Right, we'll start the meeting, first of all, with apologies. Sorry, you do the apologies, shall I? Right, we have apologies from David Mayer, Toby Sanders, Sheila White, David Watts, with Samantha Fitzgerald, where is she, as delegate, Kate Williams, Colin Foster with Sharon Sandell as delegate, Sarah Hillier, Steve O'Brien, Joe Moore, and Pratima Dattani, Scott Edwards, and Deborah Needham. And I'd like to welcome as well Chris Holmes as a new member of the board. He's the Chief Executive of Sport Northamptonshire. And I was also going to welcome the new Chair of East Northampton's Place-Based Partnership, Prince Caesar, but he's not here at the moment. So if he comes in, you'll see him sitting over there. Okay, so notifications, requests to address the meeting. Do we have any? No. Okay. Members' declarations of interest. If anyone has any declarations of interest, please declare them. And then we go on to minutes from the previous meeting of 19th of March. Has everyone had a chance to look at them, and has anyone got any corrections or anything to them? Everyone happy with them? Okay. So in which case, do we sign them or do we
just agree them?
Yeah. Okay. Does everyone agree in agreement of the minutes of the last meeting? Okay. So we go on to action log. We're rattling through it, but I expect that's forced. The other items will take longer. First of all, we had sponsors sought as part of the draft North Northants Health and Wellbeing Strategy for each of the 5 priority areas. That's an ongoing task. Arranging board development sessions to bring together organisations working in the 5 priority areas as per the draft Health and Wellbeing Strategy, and that's also an ongoing task. There are also outstanding items from the March meeting, and that's it says CWFs, but they're now been renamed to be PWPs. Am I right? PBPs, yes, sorry. I haven't quite got used to that one yet. And LAPS, to work with the Health and Wellbeing Board to look at youth-led project to get their views on vaping, linking with Place to ensure no duplication. That's ongoing with collaborations due to start in the new school year in September. Another one, discussion to take place around locality-specific support that can be offered to the Wellingborough LAP by the Combating Drugs Partnership, and that's an ongoing task. And Support North Northants continuing funding commitment that was drafted last time and sent to appropriate partners. That's an ongoing task. Responses have been received from most recipients, but not yet all. Yeah.
Thank you, Chair. Just to pick up on the item around Wellingborough LAP and drugs, it's not actually around the Combating Drugs Partnership, it's around support to Wellingborough LAP around drug services and support. And just to let you know that we have started that discussion around how our services liaise with the LAP in Wellingborough to make sure people have got the best possible offer in relation to that. So that is ongoing and we've started that work.
I thought perhaps you might be going to say about the Support Northants and the funding. Yep.
I can also give an update on that item if that's helpful. So people remember that at the last meeting we talked about concerns around support North Northants. For people who aren't aware of what that is a kind of model of social prescribing that's working with really quite significantly challenged individuals at times, but not entirely, but the more challenged. and is linking with adult social care, particularly around helping people get the right sort of support so they don't escalate, but also making sure that we work together in an integrated way. That funding was coming to an end, and the request had been that partners considered putting money into that so that we could continue at least for a period to do a really thorough evaluation, and also to look at how that then linked with the ongoing work across the system around proactive care, because that is part of that model. What we do know is that we've had some funding agreed through North Northants Council. We've had the ICB have agreed to support us as well, as have a number of other partners in housing and in other areas. So we are actually able to continue that, which is really excellent news. And the framework for the evaluation is also now being finalised. So we'll have a really good, solid evaluation, which I'm hoping will allow us some return on investment as well.
Thank you very much. Thank you very much. This is actually the last Health and Wellbeing Board that Ali Gilbert will be attending. So I'd like to thank her for all her input, all her hard work, and I'm sure other members of the board will join me in saying thank you and good luck in the future in your new role. And I'd just like to... No problem. Okay. So we have a little problem with the glare from that window sometimes. So that's really sad thing that Ali's leaving us, but good luck in the future. And I'm really excited to see all the work that's been going on with the health and wellbeing strategy and the hard work that's going into formulating each of the priorities. So the next item on the agenda is the two items, the Keeping Active and Action Plan for Tobacco. And I think the tobacco is going to be the first one, the update, and then the sport. But Jane is going to introduce it.
Thank you, Chair. And can I also just add my enormous thanks to Ali. The huge amount of work that you've done around place has really been an really important backbone for what we're doing in the health and wellbeing strategy, because you've given us that really strong emphasis on how we work at place with our communities. And we are going to miss you, Ali, and we haven't quite come to terms with the fact you're leaving. But thank you so much. So I just wanted to take just a minute, literally, to remind us all where we are with the health and wellbeing strategy. And we did agree to take a different approach for this health and wellbeing strategy, which is active and iterative. So what we're looking at doing as a partnership is putting together a strategy which is completely aligned to the other areas of work that are happening strategically, particularly Live Your Best Life, which is incredibly important to all of us in terms of where we need to get to as an economy going forward. We also wanted to do a strategy that really built on our assets. So what we don't want to do is duplication. We know we've got fantastic assets, we've got lots of existing strategy, we've got lots of existing groups doing amazing work, but we've also got amazing assets in our voluntary community sector and lots of different parts of our economy that are really important that we build on, because that's where we can get great strength from. We also said we wanted to look at existing infrastructure in other ways, so our local area partnership, our place-based partnerships, which were previously called CWFs. This is what we need to do. We need to build on that to get really into our communities and do something a little bit different. And Chris is going to talk a little bit about that in relation to tobacco in a moment. But it's about being innovative. So what we want to be able to do is both say, yes, we've got great assurance across our system that these things are happening, that we want to see a change in. But where we don't see that change, we might want to do something different. So, for example, with smoking and vaping, we want to do some work with young people about how do we do that really important work to stop young people vaping. Quite a lot of young people who are vaping, it may be they wouldn't have smoked. We don't know that, do we? But what we do want to make sure that we're doing is really supporting young people to make the right decision around that as they get older. And we want to do that really based within our communities. So another piece of work we're doing there is working with people in Corby around how do we actually get to those groups within our populations who perhaps they might need a different sort of offer in terms of smoking cessation. So we want to build on that and do something innovative. And of course, we want to work in an integrated way. The health and wellbeing strategy cannot be delivered by the council. It cannot be delivered by individual organisations. It's up to all of us to be part of that. And we hope with this model that we're taking forward that we'll be able to achieve that in a much better way. So thank you.
Thank you very much. So, Chris, did you want to speak?
Yeah, just a few words of introduction. Thank you, Jane. As members will recall, last time we had a long discussion about smoking and vaping as the first priority. And what we're going to do now is have an update on not the what, but the how. Because what we talked about last time was the what should we be doing about it. And my colleague Pippa Williams, next door but one to me, is going to be doing an update on the how and how we're going to be putting this into place. And then when that's done, the next priority, keeping active, my colleague Chris Holmes here from Northamptonshire Sport will be presenting the paper that's in the pack, and then we'll have some time for discussion. Okay, so over to Pippa. Thank you.
Thank you, Chris. Good afternoon, everyone. So I'm Pippa Williams, an acting consultant in public health in the North Northants Public Health Team. And as Chris has introduced, I'm introducing this paper, which is a progress update on the strategy programme on smoking and vaping. So this paper follows an earlier paper on the strategy which was considered by this board in March. And at that time, the programme area was named tobacco, but we've now moved and adopted that name of the smoking and vaping programme. So I'll just give an overview of the paper to draw out the key points. The report covers again some of the background information on smoking and vaping at a national and place level, highlighting the significant impacts of smoking on our local population and also the concerns around e-cigarette use in children and young people. It also sets out the additional grant funding from the government, which has been received by the public health team, and that's to specifically support local stop smoking services, so part of the programme, but not all of the activities we have. So what I'd like to focus on is an overview of the programme delivery plan, which has been developed for this smoking and vaping programme. And this programme, its aim and objectives have been developed based on the previous paper in March, the feedback which was received then, as well as feedback from the North Place Delivery Board and the Strategy Programme Oversight Group. So the overall aim which has been set for the programme is to reduce the prevalence of smoking in our population, reduce inequalities in smoking prevalence between population groups, and also address concerns about the use of e-cigarettes in children and young people. And 4 objectives have been identified to achieve that aim, with an initial work stream of activities under each of those objectives developed. And I'll just run through those 4 work streams, highlighting some of the initial activities. So the first work stream is to increase the number of residents supported to stop smoking through our local authority stop smoking service, but also through our NHS services. So this is where the additional grant funding from the government, which has come into the public health team, can support that local stop smoking service. So our primary aim with that funding is to expand our stop smoking team, which is a slight disservice. So we are aiming to double the size of that team with 3 new advisors, 1 specialist advisor and an ops manager to manage that sort of doubling in size of that team. So we are currently out to recruit for the 3 new stop smoking advisors and moving forward with the other recruitment as well. As part of that, we're also looking to recommission the provider of the stop smoking aids, which clients can access through the support they receive, and that's to help us achieve a bit more of an efficient model for running that service with the size of the new team. For NHS services, currently support's being implemented to embed 2 maternity tobacco dependency advisors within the maternity services. And the NHS and local stop smoking service are working together to align that. So they're working on a single IT system, and they're also holding joint reflection meetings for the advisors so that the 2 maternity tobacco dependency advisors have that wider support from our stop smoking service and they can share learning. Our second work stream is to identify and provide targeted support to population groups with higher prevalence of smoking. So that's the work around inequalities and trying to reduce those inequalities between our population groups. The 3 initial groups in Northamptonshire that have been identified and prioritised are routine and manual workers, those smoking during pregnancy, and also people living with severe mental illness. So we know that in North Northamptonshire, our smoking prevalence is higher in those population groups. So under this work stream, initially, it's a focus on a sort of a variety of communication and engagement activities, with the aim of those to understand the reasons for smoking in these populations, identify ways that we can support them, and that's a bit of what Jane's talking about, that we might need to consider new ways of delivering our stop smoking services to support those populations. And the initial activities there are with routine and manual workers in Corby. So, and that's going to be working through that place-based LAP approach. So a couple of weeks ago, we introduced the strategy programme and the smoking and vaping one to the place-based partnerships at their joint meeting. And we'll be attending the Corby LAP, which is tomorrow. And as progress is made, I guess, over the lifetime of the strategy to support those 3 initial population groups, we'll continue to sort of review any further groups in the population who need that targeted support. The third work stream is to implement prevention activities focused on smoking and vaping in children and young people. So under this work stream, several activities are underway, with the primary focus being that community engagement activities to understand children and young people's views and co-develop with them prevention activities which will, we hope work to reduce the use of e-cigarettes and smoking. So in the short term, this includes some focus groups with secondary schools and also collaboration with students at Tresham College. Both of those have been initiated and are due to pick up in September in the new term. And we have some guidance and resources already provided to our schools via the Healthy Schools team. The fourth work stream is to disrupt the sale of illegal tobacco and e-cigarette products and reduce the underage sale of those products. A specific project has been initiated by the Public Health team in collaboration with the trading standards, and that will fund an external provider to complete an intelligence review of any hotspots of reported activity to us, a programme of test purchasing, and then also moving to develop an awareness campaign for the general public on illegal products and underage sales. They're also planning an evaluation of that so we can build in some learning around what works. So that's the sort of overview of progress, and as in terms of sort of next steps, we intend to establish working groups to support the 4 objectives and work streams to sort of embed the shared ownership of these and support joint working. So we've started to develop those, but we also invite anyone to approach us if there's a specific work stream which they'd like to participate in. And we'll continue to report the progress and challenges monthly to the strategy programme oversight group.
Thank you very much. Does anyone like to make any comments, Jane?
Just as a small reminder about that oversight and strategy group. So we set up a slightly new or different governance model, so that below this board is a group that meets on a monthly basis, where all of the action plans for all 5 areas of the strategy are fed up to, and we have a highlight report type approach where we look at where the barriers and where work's going well, but actually critically where we are finding issues. And as we go forward through the programme, that will be fed up to this board as well, because there may be some challenges that we need your help with. So that's just part of that governance procedure. The other thing as well, we've talked all along about how we link in with other existing infrastructure. So I just want to give people assurance we are linked into the Tobacco Alliance with this piece of work, and we're also working with the cross-system prevention pillar that's recently been set up. So we feel our governance is very strong around this. What we need to do is take a little bit of risk in places, I think, to say if we're doing something different, what does that look like? And to give assurance as part of that, we will only do that with evaluation. So we have an evaluation specialist. Also, there's an opportunity for us to get some funding to actually have a completely independent evaluation done on this. And that is going to be our sort of gold standard approach. We've got to evaluate it, we learn, and then we see if we can roll that out. If it doesn't work, we'll try something else.
Yeah. Naomi.
Thanks very much. I have to say, it's a really good paper, and it particularly chimes with what the ICB said is its core outcome measures, and one of them was smoking, and particularly smoking in pregnancy. Massive contribution in terms of health inequalities, because the social class gradient in smoking is absolutely perfect, in a sad way. The point I wanted to make, Jane, was the last point you made about evaluation. Delivering services is not an outcome. The outcome is do people stop smoking? And so I'd like to see a report back to this committee. And I think that the bespoke approach is really, really important, because the initial attempts at stopping smoking were hugely successful, and that's why we have increased health inequalities. It's for whom it didn't work, we have to try something new. So I think that approach is absolutely right.
And just to also give you assurance, Naomi, that we are aligning all of the metrics for these metrics that are being reported, for example, through the ICB and NHS through to NHSE. Yes, so we're doing that in a very joined-up way, but I completely take your point, because some of the things that some of those KPIs in themselves are not outcomes. Actually, a 4-week quit doesn't tell us the longer story for that individual. So we want to build something in that does give that longer view. The other thing we want to do is be reactive. So if we find through the evaluation there's things we want to change, we want to do that iteratively. But we'll only do that if we have a very strong evaluation approach.
I think very good in 4.2, where it points out the stats currently on the women smoking in pregnancy. It's already gone down from 11% to, it says 7.8, but I have a feeling it's a little lower than that now, 7.4, I seem to recall. So that's a real outcome. Yeah. Anyone else? Ali?
Thank you, Chair. Just want to make the point in the connection with the place paper later on the agenda. This will only be as good as making sure that the LAPs and the place-based partnerships are functioning and maturing as part of the phase 4 development. So the two elements come together, as well as then the engagement and ownership by the population. I'll go into more detail when I present my paper. Thank you.
Thank you. Yes. I was really quite taken as well with some of the stats at 7.8.2 on the CO2 emissions and having to plant 132 tree seedlings grown over 10 years, etc. I thought that might actually appeal to some people and say, well, that is an outcome if you stop smoking. So they might respond to that, whereas they wouldn't to just stop smoking, because it doesn't gel with them. Oh, sorry, Rob.
Chair, many thanks for the paper. It was just a point of offer, really, with regard to action point 3, objective 3, implement prevention activities focused on smoking and vaping. Yep, certainly, sorry, I will move it closer. Implement prevention activities focused on smoking and vaping in children and young people. We've got a really large group of young people that work in the emergency service cadets, both, well, for all of us. And I suppose that offers there, if, with regard to your evaluation, your piece of work, if you want to utilise us and utilise our young people, see that as an outlet, by all means get in contact, or certainly we'll get in contact with you. But it's just a point of offer.
That's really good, because it is all about joined up working and what other partners can bring to the table. So yeah, okay. So I think do you need to come back on any of that, Pippa? Or?
No, I think just say yeah, definitely would love to connect with the young people that you're working with on that programme.
So board asked to support the programme delivery plan, note the progress made on implementation of the work streams, also asked to note the budget allocated as part of the Smoke-Free Generation funding awarded to public health, and support it being spent within restrictions to support smoking prevalence in the county. Is everyone happy with that? Okay. So we'll go on then to Chris. Would you like to tell us about the active living?
Yeah, just to say that this is the second of the health and wellbeing priorities that we've agreed. And I'm very grateful for Chris Holmes from Northamptonshire Sport, who's been instrumental in helping to write the paper, along with a whole range of other people who are in the paper itself. I'm very grateful to everyone's contribution to it, because even though I've drafted it, I can't do that without support from everybody. And it's shown a lot of ownership of this particular agenda. So I'll without further ado, I'll pass it over to Chris Holmes, who's going to be introducing the paper and stimulating, hopefully, some discussion. Thank you.
Thanks very much, Chris. Hello, everybody. My name's Chris Holmes. I'm Chief Exec Northamptonshire Sport. We're the active partnership for Northamptonshire. And just for anybody who's not aware, there are about 43 active partnerships across the whole of England. We're a construct of Sport England core funded to try and help more people get active, fit active lifestyles into their day-to-day lives and perhaps play more sport. And it seems so appropriate today to be talking about keeping active. We're right in the sort of the peak season, aren't we, summer-wise with sport, with the Euros on today and Wimbledon next week. Paris Olympics just around the corner. Tour de France starts this weekend. And of course, the event that's probably stopped you all from parking a little bit closer here today, but the Children's Triathlon, which is taking place just in the car park on the doorstep there. So there's about 1,800 children from primary and secondary schools that are coming to the pool today and enjoying a bit of time in the sunshine. So really keen to move on to the debate and discussion and your ideas and thoughts. But I thought perhaps, I'm sure you've had a chance to read the paper. I thought it might be helpful just to try and pull out what I feel to be the three key messages that thread through the paper. And the first message is about it being so much more than sport. It is about everyday life and movement and active lifestyles and just fitting that element of more movement into people's day-to-day. We have some fantastic sports clubs and facilities around Northamptonshire, and of course they all need pitches and halls and pools and all those sorts of things as well. But for it to really be sort of innate and ingrained into people's day-to-day lives, it needs so much more than just those formal sports. That's formal sports provision. It's about country parks. It's about the policies that provide safe streets. It's about active travel choices. And there's simple things like lighting and signage and the things that make it so much easier to choose to be active every day. And the other element of that, more than the sport piece, is that it's very much about being two sides of a coin. So whilst, obviously from my point of view, I'm really keen to see more people being active and playing sport, I'm also very keen to see the way that sport and physical activity can help meet other outcomes, be that around regeneration or diversionary activities or education attainment or health or whatever it might be. I think physical activity and sport can play a part in supporting those sorts of outcomes. So that's my first point about it being so much more than just sport. The second is about equality of opportunity. And I know that inequalities sits very much at the heart of the health and wellbeing work and the strategy and the Marmot principle around universal proportionalism. The idea that more groups, certain communities are going to take a little bit more in terms of effort and resource to help them choose active lifestyles. And if you think of a 100-metre sprint race, it's that element of there being some communities and some places that are behind the start line already before the gun even goes. And it's our job to try and make sure that that equality of opportunity is there for them. And the third one, I think, is around it needing systemic change. We used to think, mistakenly, I believe now, that the more activities and opportunities and things that we cooked up and put on, that people would just come, that build it and they will come philosophy. And I don't think that is entirely true. We fail to consider the sort of the whole person and all that goes on within their day-to-day lives, be they their employment status, their emotional well-being, those wider determinants of health. So for us to help more people in Northamptonshire be active and enjoy the benefits of that, and then also perhaps enjoy the other outcomes that that's helping us to achieve, then we're going to need to try and pull the levers at a policy level, at an infrastructure level, in our institutions and our communities, putting our kind of collective weight that we have here around this Health and Wellbeing Board table, our collective weight around the effort to try and help more activity in Northamptonshire. So they're the 3 points that I think I'd highlight, and it's just my luck to be the one at the front talking to you. Of course, all this happens week in, week out because of the efforts of so many more people, be they in the public sector or the voluntary sector or the private sector. We're obviously asking for the formal part in the paper about the recommendations that are laid out to be approved, but I'm also dead keen to use this informally in a sense of asking for your collective support, your reach, your influence and your backing for our efforts at trying to help more people keep active in North Northamptonshire. So I'll stop there, and I've got a few prompts or questions if people would like that, but otherwise I think I'll probably just leave the floor and see what thoughts or ideas people have in response to the paper. Thank you.
Okay. Who would like to come in on that? Anyone like to contribute to that? I mean, it's a fantastic paper, and it's got a lot in it. The recommendations are at item 3, so you can see there the things that are being asked to consider. Chris.
Just also to highlight the part of the paper which talks about keeping active can be a benefit to everybody. In addition to what Chris has just been saying, some people sometimes have the attitude, it's not for me because I've got issue X. Well, it doesn't matter whether you're tiny in age, very elderly in age, or what, doesn't matter what you are. Exercise can be beneficial to absolutely everybody. But it does have to be tailored. So, the point about it's not all about sport is absolutely right. But keeping active applies to absolutely everybody. And a part of the challenge is to make that available to absolutely everybody in a way that makes sense to them and their families. So I just want to sort of highlight that, because everybody around this table, around this board, can have some impact on keeping active, whether it be them personally, the organisations that they represent, or certainly their families as well. Thank you.
Okay. Naomi.
So I really like the distinction between keeping active and sport, because I hate sports. But in this building, I find it really hard to use the stairs. When I come in, I'm directed towards the lifts, and I leave and find the stairs and then get lost going. So I just think there would be signs on lifts everywhere to say, if it's 2 floors, walk, or 3 floors, just those are the little things that I think change our normal behavior and our expectations. So let's have signs on the lifts to walk.
I think you can't access the stairs unless you've got a pass either, so...
Just to agree entirely with that, and I did work in an organisation that on each flight of stairs, it would tell you how many calories you'd burnt off. And I have to say, that made people very happy. So there's some of that innovation stuff in there, and I think every organisation here will already be doing things with their workforce, for example, which brings me on to my main point, which is when I read the report, Chris, just the amount of assets we've got is quite mind-boggling, isn't it? We've got so many things in the voluntary community sector, with the councils, with all sorts of different organisations, private organisations as well. And we do have the key strategy around movement, and I'm aware that the council's active community strategy is also imminent and is going to really feed into this. And I guess what I wanted that assurance on is that when we take this into action planning, how do we make sure that we get assurance across all of that, but where do we pick out the bits that perhaps we need to have extra focus on? And I guess that's part of how the subgroup that forms around this really identifies that. So, for example, with smoking, we identified that routine and manual workers were just not quite getting it right somewhere. So we have got the ability to be innovative in this space, but it's about not duplicating. I read through that list of assets and just thought, wow, fantastic, this is great, but where's the space that we need to really look at if we're going to do an active strategy?
Thanks.
You do.
Shall I come back very quickly
Yes,
on that? Yeah, and I mean, just to use some examples of that insight-led approach to identifying the opportunities. There's I don't know exactly which section it's under, but there's a section in the paper about an opportunity at the moment through Sport England called Place Expansion Work, which we've been working really closely with Ali on. And some of it's about, I suppose, being opportunistic. If there is an investment opportunity out there and us being able to draw that in. And it's very much about working with some of our communities in North Northamptonshire where we know inactivity is greater. But not just arriving with a coach load of coaches and balls and putting stuff on, but working with that community and alongside them and building their capacity to bring active lifestyles into that community's everyday life. I think there's also the bit about being proactive as well and looking through the information, the data, the insight that we draw from our local communities and and seeing what else there is. Whilst there is a wealth of provision out there, it's clearly still not hitting everybody's need. And I think too often we sort of pitch the be active first element, whereas actually the elements of it being something for people's social isolation or their education attainment or something to support their greater well-being through the vehicle of joining a dance class or a jogging group, that we need to be much more adept at that.
I think also it shows from the figures that we've got some way to go with the amount of people that are active or have, the right level of activity. So there is quite a bit of work to do. I was quite taken also by the fact that it started from zero rather than just, perhaps 5 years old. That, don't forget the babies and, the over 75s as well. Prince.
Sorry, I was a bit late in coming. I've listened to it. I haven't had time to digest the report in its entirety. But again, yesterday I was talking to this lady, a black woman, and she said, I would love to walk, but I haven't got the time. And I guess that tends to be the story of most people, not having the time to really, get active. And I'm thinking, what can be done? And I think you've alluded to that in terms of not just the active, but, underpinning issues or things that are preventing or barriers that are there that actually need to be taken away in order to enable these families to be able to be active. And I think I would love to kind of see what kind of model or what kind of strategy can be adapted in order to kind of alleviate some of the underlying impediments in order to get people active.
Sam.
I think you covered it when you were a little bit for me when you were talking before about some of the opportunities. So I really agree with the kind of the activity element of this, and I was instantly thinking about, even some of the things that are in my own report that I'll present on later, strength and balance exercise, but actually they give people so much more than just strength and balance. So we know that by running some of those with local communities, even once the course is over, those individuals chose to keep that connection, to keep that activity and take that back into their own their own locality. So I think we've got some real opportunities to strategically join up some of what we know are our key pressures and service demands, and really promote that. And then what you were just saying there, Prince, well, actually there's something there as big employers of setting a precedence that actually we encourage our workforce to get active during their work time. We encourage you to step away from your in-desk. We, promote the fact that you need to go for a walk around the block, and we give people permission. I think sometimes people feel that they lack permission to look after themselves in that way. So from my perspective, really, really welcomed and really keen that we join those dots up across the piece, because I think we've got big opportunities here.
Okay.
Were you coming back on that one, Chris? I shall be quiet until you do.
Just really quickly, yeah. I mean, I'd got a little example written down here, and I thought, well, I'll skim over it actually because we're tight. Could be tight for time, but it's an example of Mike, who was Jane will have heard him, I think, at the Active Ageing Conference at the university. He's a 90-year-old gentleman. He'd lost his wife 3 years previously and become very socially isolated. His general practitioner referred him to the Otago strength and conditioning classes that are commissioned by Public Health. There's 60-odd classes around the county each week, and he just described his journey from that point. Not only the physical journey, the fact he could balance and he could move around his house and he could go out, which he'd not done, but what came across even more powerfully was the connection he'd made with people that just simply weren't there. So we mustn't forget the spin-off benefits, if not the primary benefits, actually. And joining that up with Prince's point about time within the day, it is true, isn't it? People are really tight for time, tight for resources. And to some degree, the idea of fitting a walk into the day is not, if you're not really all that keen on it anyway, you might not do it. But perhaps meeting up with friends, spending some time socially, and perhaps through a walk. And it might be something that your workplace has given you the permission to do within your lunchtime period. That's the sort of the thing to think of, isn't it, as the driver to drive that action. Being with people, having 15 minutes chatting whilst you're walking, and what do you know it, you've got a secondary benefit of your heart beating a little faster and some exercise under your legs. But I do think also we have to do a lot of work to recognise, and we do a lot of work to recognise that different communities with different demographies have different expectations, different social norms. And so whilst we might think that our sports facilities, for example, are accessible, to certain community groups, they just aren't. They're not the places that their community are used to going to. And we need to provide a bit more help in terms of the customer journey for them to access the local swimming pool or such. Thank you, sorry.
I think, you know, accessibility, you were saying there, and I think it's in the report about the cost of some of the facilities. But I think also one of the things is to make things fun. There's a couple of fun days over the summer in different areas that active communities are promoting, and there might be an activity that somebody might have never thought of. They see a little snippet there and they think, oh, I'd quite like to do that. It's something I can fit around my normal day. So it's just finding, you know, it doesn't have to be sport, but it can be something that's really interesting to people. Okay, so we've got these recommendations. James, just going to speak first.
Just a quick observation to say that of all the people I've met, actually, Chris, Mike being like a complete star, I just remember everything he said from that particular talk, but the council do wellbeing walks and all sorts of different things that are going on in the communities. That issue around social isolation and meeting people is probably one of the biggest outcomes, actually, of all of this work. Although Mike, when he stood up on one leg and lots of other people couldn't, I thought, wow, that is pretty amazing that it got that. The point I wanted to make was about integration with both the children and young people aspect of the health and wellbeing strategy, because we know we've got to get that right. And just Sam made me think a little bit about the family hubs, and so did Prince. So as a economy, we're looking really closely at the moment about our early help offer. And we're looking really closely at how do we make sure that young people start their lives in the most healthy and positive way, and how do we support people to do that. In your report, I really found a bit fascinating where you looked at how much activity is required or suggested or for different age groups. And one of the big challenges, I mean, my children have grown up now, but we will all know, and I've got stepchildren a lot younger, it's a challenge, actually, to get young people off devices sometimes. It really is. And I do think that is something we need to think about technology. But we need to integrate all of this with the children and young people's offer across the economy, I think. If we can get people doing it really early on, get our Healthy Schools programme fitted in with that. I mean, this amazing thing outside, 1,800 children engaging in activity, that's how we'll bring the benefits, I think. But I do think we know there'll be challenges along the way, and supporting young people to be active isn't always easy. And I know that as a parent, it can be challenging, but I think if we take that really multifaceted approach, we should be able to get somewhere really positive.
Thank you. Ali, you want to go?
It's just to give the Health and Wellbeing Board assurance that we're connecting the work with the priorities that are coming up from Place and Labs. So, for example, community transport, which is social isolation, because people say they can't get to us sometimes, so making sure that it doesn't substitute the walking and the activity, but all these priorities connect, which goes back to what happens at a local level and local area partnerships. And the other point I'd like to make is the LAPS will be launching public websites for each lap, and that's an opportunity to promote exactly what you were describing, because what we're getting fed through the laps from the residents, that they're a little bit overwhelmed with all the assets, that they don't know sometimes where they're at. So we need to simplify this, we need to improve the accessibility. So the two transformational pieces of work and delivery of the strategy will connect, and I know I'm working closely with you, Chris, on that. Thank you.
So the board are asked to note the contents of the report, support the principle of equality of opportunity, also to support the active community strategy and the Move Northamptonshire framework, And the board are asking the Northamptonshire Active Communities Partnership to lead the recommendations in the report. And everyone happy with that? Yeah. Chris, did you want to come back?
Thank you, Chair. And to say that at the next meeting of this board, we will be bringing, as Jane indicated at the beginning of the meeting, an update on progress in relation to this. We will be setting up a little group to actually do that, but that hasn't happened yet. But we will bring an update on all these different actions here and how they're being taken forward. And we'll also bring a paper on the children and young people, which is the third priority. So it'll be a similar format to this. So on an ongoing basis, we're doing that phased approach to all these different priorities.
Yeah, it's good to see updates as we go along so that we know where you're up to. Good. Okay. Next item on the agenda is the SEND inspection report. Just a reminder, the SEND, Northampton SEND Local Area Partnership is made up of strategic leads from education, health and social care, who are responsible for the strategic planning, commissioning, management and delivery of services for children and young people with SEN. And this presentation follows the Ofsted CQC inspection of those services in March 2024. So Charlotte, would you like to present the report, please?
Yeah, thank you, Chair. Hi everyone, thank you for having me today. I'm Charlotte Franks, I'm the interim head of SEND for Northants Council. So I'm here to just give you an update on the Ofsted and CQC inspection that we had. The actual inspection was in January of this year, and just to kind of talk you through the process of that and the next steps coming from that. So the local area partnership for SEND is made up of a number of organisations who all have specific duties under the Children and Young People's Children's Act around special educational needs. So that it incorporates quite a lot of organisations into that local area partnership and their responsibilities towards that. It looks at the provision of services for young people with special educational needs between the ages of 0 and 25 years old, and it looks at how those services provide for families within the local area. So a large element to that is the local authority, who are responsible for sort of leading the inspection through, but it has key partners from a range of health agencies, from school and education services, and from social care, both children and adults. There was quite a lot of partners involved in that inspection. I think one of the key parts to note is in our self-evaluation of those services, we've recognised that there are lots of areas for improvement for children and young people with special educational needs. So we weren't presenting that the services are really thorough and well delivered. We were recognising that there are lots of areas for improvement, and the inspection agreed with that self-assessment that there were lots of areas to improve. So if we could just go to slide 4, please. So the overall outcome of that inspection were that there are widespread and systemic failings leading to significant concerns about the experiences and outcomes of children and young people with special educational needs. There are 3 different outcomes that can come out of that inspection, and this is the lowest of those 3 outcomes. So as a result of that, we're then required to prepare and submit a priority action plan, and we have a notice to improve from the Department of Education that goes alongside that as well. So next slide, please. Thank you. So the headlines, we had 4 areas for priority action. There were 6 areas for improvement, and there were also 11 strengths that were found across the partnership. So if we could just move on to slide 7. Thank you. So the first priority action was around partnership working. So this is how all of the organisations worked together in a sort of cohesive strategic direction. There was found that there was planning in place, but it was sort of within its infancy across the partnership, and wasn't quite yet built or cemented in, with clear actions kind of demonstrating improvement over time. So that was the first one. The second one was around joint strategic commissioning, and this is in particular between the local authority and health services. There wasn't a clear joint commissioning strategy that had in place to ensure that services were best placed to support children and families and their children and young people and their families. And then the next slide, please. Thank you. That the governance arrangements for holding services to account, again, were sort of in their infancy and weren't yet effective at holding each other to account. And then the last priority action was around accurate and early assessment of needs of children and young people and the delivery of services in order to meet those needs. Again, that was an area of priority action for the area. I won't go through each of the areas of improvement and strengths, because otherwise we'll be here for a while and you've all got access to the presentation. But there were other areas of improvement that were built within that that need to sort of feature within our planning going forward. And there were 11 areas of strength that were found across the partnership from a range of different services and a range of different organisations and how they worked together. So there's absolutely some learning that we can take from those areas of strength as well. So following on from the inspection, there are a series of things that the local area partnership now need to do in order to move forward with that. The first of which was completing a priority action plan. So this is a plan that outlines, as a partnership, what we're intending to do in order to move services forward to meet those 4 priority actions, but also the 6 areas for improvement that were found within the report. The priority action plan took a bit longer than we'd hoped in pulling that together, and that's because during that period where we needed to pull that action plan together, West Northants were then started their local area inspection, and 2 of our key partners, our health partners and our social care, children's social care, were involved in the West inspection. So we were given a bit of an extension to do that, to allow for that second local area inspection to take place, and we've recently submitted our priority action plan, which has been accepted by Ofsted and CQC as being relevant and the right kind of plan in order to move things forward. So in terms of what next steps look like for the partnership, so if we could go down to slide 22, if that's okay. Thank you. There are now a series of meetings that we need to engage in as a partnership in order to demonstrate our movement in the right direction with our area action plan. And they roughly take place once every 3 months with a different type of theme of meeting each time. So some are a bit more of a stock take type meeting, and others are more of a deep dive into specific areas that they'll let us know about at the time. So these, again, are both meetings are delivered by Ofsted and the CQC, and they're looking at the local area partnership as a whole. Alongside those meetings, there are also regular stock take meetings that take place with the Department for Education as well, to provide assurance to those that we are on track with moving forward, and with NHS England. So the Department for Education and NHS England ones happen alongside these 3 monthly meetings, with a full monitoring inspection to take place in 18 months' time, and a full re-inspection to take place in roughly 2 to 3 years, depending on the progress of the local area partnership at that time. So I won't go through any of the other kind of slides unless anybody specifically would like me to. And is there any questions?
Okay, any questions, Charlotte? Naomi?
Just a comment by explanation, which has already been alluded to, but it's really important. The West review hasn't been published because we're in the pre-election period, but I would be incredibly keen, and I'm sure the Children's Trust would be as well, if there's a lot of joint working between the two local authorities, because this is the area where health and local authorities really need to work together. You know, it's just incredibly important in terms of interagency cooperation, and because we cover both local authorities, it would be really helpful if we were going to do the Integrated Care Partnership meeting, the wider meeting, but it had to be cancelled because of the pre-election period. But we were going to spend that whole meeting, and Jill had agreed to this, and so had Matt Golby as the chair of the West Health and Wellbeing Board, just on SEND. So there's a huge amount of work to do, and I would be really grateful if we work really hard to do it together in terms of both local authorities and the Integrated Care Board within the Integrated Care system, because it is so critical in terms of education and health and social care in terms of SEND.
Thank you. Yes, sorry, Sandy.
Just following on really, we are due focused visits for the North Children in Care and Leaving Care Service over the next 9 months. And transitions will be part of that, and I think that's where we know most of our children struggle, is in that transition from 14 up to 25, and how particularly services just fall away from 18. We do need to be joining up, and certainly with the West, because we know the offer for our young people leaving care tends to differ slightly from the North and the West, and it needs to be joined up quickly.
Yeah, that's possibly something you need to be brought up at the corporate parenting board as well, if that's helpful. Sam, I think you first, then Ali, or Ali first, and then Ali.
Thank you. Just wanted to come back on that point. So Sam Fitzgerald, yes, we emailed this morning, made that connection. Completely agree. So actually, I think that transition point is one of our absolute priorities, to make sure that we get that right, that we prepare our young people for the fact that the world does. I don't think we can shy away from the reality that the world looks different post-18, but we prepare them for that, and we prepare them. So all of the things that we've talked about in the room today, connecting people to other communities, having their outcomes and their needs met potentially in different ways. But yeah, I think this is an opportunity to join some of that up. So use the mic as a potential. We've got that connection. Let's pick up that. And I know there is joint work that's happening between. It will always look slightly different from the local authorities, and actually we are evolving and in different ways, and that's okay in a way. But I suspect there will be real similarities, and if the issues are that similar, we may as well pull together to fix it. But I do know from all of the different forums that I've been in, that moving into adulthood, that transitions cohort is a real priority across the piece. So we need to use this as a bit of a vehicle to get some traction on that.
Thank you. Ali?
2 comments from me. I was involved as Director of Place in the inspection, and there was quite a lot of conversation around local area partnerships, because the local area partnership for SEND is different to the 7 local area partnerships for North Place. So I know we all know that. I thought I'd state it in the room, because the local area partnership for SEND is Northamptonshire, as ours are obviously smaller geographical areas, or ours as in a health and wellbeing board. So the 2 things connect. Picking up on Naomi's point, the integrated care partnership is critical within this, and our ICS governance is integrated care partnerships linked to 2 health and wellbeing boards, things we do jointly. So we've got that governance there. We just need to make it happen effectively. And the other last point is the Children and Young People's Transformation Partnership. So that's pan-county. So we've got focus on children and young people in the health and wellbeing strategy in place, in SEND, in a transformation. There is a huge industry here around focus on children and young people, which obviously connects in with the SEND improvements. So I think we've got a lot of work to support this and make sure we simplify a complex set of governance arrangements and delivery.
Anyone else? Well, thank you very much for your contributions. The board is asked to note the report. So, okay, thank you, Charlotte. Right, we go on to EMAS now. East Midlands Ambulance Service sharing their strategy for 2023-2028. Thank you. I'm not sure you're on. Use a different one.
Thank you, Chair, for the opportunity to share the strategy. First time here in the forum, so I think I know a few of you from before. Manik Arora, Associate Medical Director at EMAS. So just bear with me while I try to figure out the screen is behind me and while I'm presenting as well. So I take the point that last year when the Association of Ambulance Chief Executives updated the vision as well, they are trying to keep up with the change in narrative to what ambulance services were set up with, where everybody was expecting an ambulance with a view that it would be taking you to the hospital in the timely manner. But as the population changes, is that always the right answer for everything? And what do we need the ambulances for? What is the role of an ambulance in a major incident? What's the role of an ambulance in an emergency scenario? What happens in an urgent scenario as well? So with keeping that in mind, that's where the Association of Ambulance Chief Executives updated the vision last year. And we started as an organization our journey of what is the EMAS strategy in that spectrum and space. And the clinical strategy is the first of the group, in a sense, to direct the model of the care that we're going to be working towards. This has now been followed with the people strategy, the quality strategy is being refreshed as well, and there will be a digital work which is also following through in this. If I move to the next page, please. The EMAS strategy, you can see the ambitions within there, particularly not just the outstanding patient care, but the employer of choice. And it came back to the earlier discussions for me with the opportunities we have as an anchor institute across within health partnerships and health and care partnerships to what we can offer. And it's been amazing to see what the sector can actually do for the population. I say that because I've joined the organization 4 months ago and I'm still on a journey to discover the sector as well. So, and within that, along with the safe and compassionate care, I come to the questions of health inequalities. We would not have normally imagined an emergency responder to be talking about health inequalities in the same spectrum. But when we get to the point of identifying and seeing them firsthand, but then how do we get and link up with the support? And I'll come to that later on as well. And I particularly want to pick up on the point of social prescribing, smoking cessation, and the exercises that we have talked about earlier. The key measures, I'll come to the strategy side of things as well, but you'll see these ranging beyond the response times, because the ambulance sector, again, is most of the time we hear about the response time, and that's the only measure which seems to capture the imagination. But there's far more to be done with regards to how do we capture the success of an ambulance service. Next slide, please. If we missed that one. Next one as well, thank you. So, the role that we would commit to is, as everybody would anticipate, an ambulance to be there along with responders in a major incident. What is our due preparation for an incident, and what is the role that we're doing in terms of preparation and exercises with other Cat 1 responders as well. And that carries on, but that's often, I would say, out of mind because we don't always think about it in the planning cycles as such, but there's a lot of work happening in there as well. The emergency care, that's what we hear most of the time. An ambulance will be there in 18 minutes for the life-threatening scenarios of heart attacks and strokes. And how do we make sure that we are able to do that in a resilient manner? There are challenges, and I wouldn't say that there are not, but how do we recover that time scale, and how do we give the confidence for the population as well that one will be there at all times when needed? This does mean that we have to relook at what we can do for the urgent care as well. And I mention the point about the population demographic changes. If in the next 15 years we're going to be talking about an increase of 3.4 million over 70-year-old across the country, if we're talking about that, majority of it will be frail elderly. When I say frail, in terms of those vulnerable to a slightest of health insults, How do we have a service which is fit for purpose in that? And that has to change our model with regards to not always taking them to the hospital in the right manner. Can we do something on the phone with regards to the assessment and advice? Can we do something about treatments and advice when we are on the scene? And this comes to the point of signposting them to the right services as well. So what already exists? If we are advising somebody with regards to the chest infection, can we signpost them to the smoking cessation? If we're finding somebody who's falling regularly or has a first fall, how do we refer them to the Otago? Can we be the trusted assessor so that we can signpost them to the sim links rather than sending a thing which happens at the moment, send it to the GP for the GP to send it onwards, which just winds up everybody. And in our strategy, we have to keep a focus on the non-emergency patient transport as well. We don't provide that in this county, but we do that in other parts of the EMAS provision, where we are also looking at what does that mean for the outflow of the hospital, particularly when it comes to those individuals being at end of life. How do we support them, whether that's the right thing or not? And keeping the fundamentals of equity, care closer to the home, as well as the safe and effective personalized care. I come to the next slide, please. Rather than repeating myself on the key measures, I want to come to the point of why it is different. And the key difference for us will be increasing the proportions of hear and treat, what we are saying in terms of an assessment and what can be done remotely, what can be done on the scene, rather than the conveyance being the only option or the main option. And I say that because in parts of our provision, and the figure which sticks to my mind, this is not Northampton's figure, but Leicestershire figure, which was 37% of individuals are conveyed when somebody's on scene. That's not always by choice, but because the crews are trying to do the best for that individual in the community. How do we support our crews and teams to do the right decision with confidence? And that means working with a lot of partnerships. And Colin and I were speaking this morning as well. How do we get the right support? It's not just about the ambulance, but what happens to the rest of the wraparound support? And we'll be keen to hear the thoughts from place. But once we have left the scene, there's still a job to be done. And that system, that robustness is needed. I've also mentioned with regards to the health inequalities, but to do this work, we have to increase the confidence of our workforce and the skill mix. Most people imagine an ambulance service to be paramedics. There's 17 different clinical roles in there, and they are increasing from everybody from mental health to prescribers to pharmacists. We don't have prescribers as many in EMAS, but other ambulance services do. I've seen palliative care nurses. There's so many different roles. So that complexity, that workforce mix, as it's evolving, what would it mean for the rest of the system as well? Next slide, please. And this is the complexity of the conditions and cohorts of the population that we're dealing with. This is trying to cover the largest of the caseloads that are coming through on a daily basis, and how do we do, and how do we improve the care consistently? How do we identify the unwarranted variations so that we can focus on it? And the year one focus for us are falls, frailty, end of life, cardiac, respiratory, mental health. And if I cover these three conditions, you can just think all of the urgent and majority of the bulk coming through. Mental health, there's already work which is happening as a business as usual in terms of maternity and high volume service users. So I won't even say that in an area of transformation. These are the conditions that I've said are the largest volume in bulk. But what does that mean for the workforce model and the delivery model? And I'll come to hand over to Mick in the due course on that. The next slide was purely going to cover to why we're doing it. And I've covered some of that narrative in my description earlier on. The number of long-term conditions which are increasing. Again, you can tell I've probably been reading too much of the CMO's report from last year recently. The numbers which are increasing are COPD, heart failure, diabetes, mental health. how do we support those individuals with long-term conditions in the right place? And that COVID, acute bed pressures, the population which is needing the elective backlogs, the confidence which has been hit with the out-of-hospital queues as well. That's the reason for the strategy and the focus that we currently have. I'll move to I'll hand over to Mick with regards to the operating model.
Thank you, Manik. Good afternoon. My name is Mick Jones, the Divisional Director for Northamptonshire. And as Manik says, I think gone are the times now where it's you're in trouble now, you're going to get an ambulance, you're going to get a rare or a number of options where we can take you to or signpost you to rather than take you to A&E. And I think it's fair to say as well, nationally where A&Es are and hospital delays, we have got to do something different. We can't continue in this model of everybody goes to A&E. And also it's probably not the right place to take everybody anyway, because their health needs are so wide. So hence why we have got to change. So on this slide here, I won't go through that long algorithm on the left, it's there for you to read, but the principle is we'll get the call, we'll assess on the phone, as Manik said here, and treat, and then make a decision what we're going to do with you. Either signpost you to other providers, or if it's deemed it's life-threatening at that time, we'll respond straight away as it goes there to see and treat. But also to the right of that triangle, inverted triangle, is that non-conveyance. And just to touch on Northamptonshire's figures, pre-COVID, we was non-conveying, that's not taking people to hospital, 37% of the time. So that was quite, and I remember this was probably 2018, it being called woeful by the then CCG, because we should be doing better. During COVID, and now we are regularly only non-conveying 55 to 60% of our patients. And yesterday, being an extremely busy day, we non-conveyed 63% of patients. So people that we attended, we either left at home and deemed it safe to do so, or we signposted them in a different way. And you can see how the confidence has increased of our staff go out through the pandemic and out the other side. And my own personal opinion through the pandemic was, thought was, we'll revert to normality, but we haven't. It's stayed there and showed that improvement, which is fantastic. So the next thing would be, if it's deemed appropriate, we'll transport and treat and convey, because there will be occasions when people will still need to go to A&E. So we get the next slide, please. So rather than just reading that out verbatim, as you can all see it, these are the key priorities for the 24-25. Is implementing that new clinical model, that diagram that was on the left of the previous slide. One of the biggest things that I would like to see in Northamptonshire is the local divisional clinical hub with our specialist practitioners. We did this in Northamptonshire probably 18 months, 2 years ago, and we did it with asking forgiveness rather than permission with our specialist practitioners, and the success of it is now being rolled out, going to be rolled out across the whole region, and that is having local specialist practitioners in a hub, probably in Northampton North Ambulance Station and Kettering, one north, one south, 24/7. So they will look at our staff and say, right, I can deal with this over the phone, I can deal with this by X, Y, and Z. But it also gives extra support to our guys on the road to say, I've got this, folks, what do you think? Where can I go? And it's building that network. And that is the thing that we are now building, and we're very, very close to implementing it 24/7. So if anything else this year, that is one of the key priorities that we will achieve. And that will expand, and that the skills of these people will expand as it goes along as well. And that is it from me. Thank you. Is there any questions?
Yeah, Jane.
I always have a question, obviously. Thank you, Mick and Malik. That was really good. And I read the strategy, thought it was really interesting. The first thing I wanted to do, actually, was just to thank EMAS for the work that your teams are doing with our teams around notifying us around patients they're picking up that might be suffering from a drug overdose or something they're not expected. It's fantastic, and it's really getting us so much great intelligence. So I really wanted to thank you for that. But the other thing I wanted to say is I'm really heartened to see the word health inequalities and prevention in there. And EMAS and ambulance staff are that strange group in that they can meet people at primary prevention, secondary, tertiary. They go across the whole spectrum, really. And I'd like to maybe outside of this meeting pursue how we can support each other a lot more. So you mentioned about smoking cessation. If you're going to focus on respiratory, it would be really good that your staff feel really confident about how to get people into local smoking cessation services, or if it's about frailty, the Otago programme is really successful and doing some really great work. So the more we could work together on that, I think would be really helpful and bring around some benefit.
Yeah, lovely. Thank you, Jane. Yeah, most definitely, and we're welcome to do that. But go back to Rob's point earlier on, we're linked into the cadets as well. So I guess another point we could triangulate as well and see what we could do.
Yeah, okay. Trevor. You've got a working one or a non-working one?
I can share. There we go.
Not often I'm silenced. Thank you very much for that. And certainly from the acute sector, I can say we appreciate greatly the work that's been going on. I know going back a few years ago, there was a lot of finger pointing either way, and I think we've got the sort of relationships have matured massively locally, and appreciate that. I just want to quickly reflect, because I think one of the bits that I didn't see here, but I've seen and witnessed, was the power of digital in how, in this particular case, it was 2 years ago, a very elderly lady on a Friday night in Northampton had fallen, and your team came out, dealt with her there, and she stayed with somebody coming to support her that night at home, rather than spending potentially 10, 15 hours in A&E, and most likely then spending weeks in the hospital. So the more we can look at different ways of supporting that exchange of intelligence, and it was, your team said it was because they knew of this lady's history that they felt comfortable with supporting her staying where she was rather than taking her into NGH. So, and that would apply wherever, but I don't know where we are on the digital, but I think that's something I don't see here, and I just hope that it's something, and I'm sure there is, a focus on.
I'll gladly take that one. So there's one line in the presentation which says the NHS pathways, but largely it's not there. That's because there's a separate digital strategy which is being worked through as well. And NHS pathway is our software to do the triage, but it also helps signpost where we need to get to. At the same point, Jane, I come back to the question of health inequalities as well. Why do we have to rely on an individual remembering to take an action? Why can't we create the prompts within the system? You've just dealt with somebody with a respiratory problem. The next suggestion comes along. They are in this area. This is the service. Make an automated referral for an Otago team as such because they meet the criteria. And we want to get to that state, and we're not at that state, but that's the ambition within the digital strategy as well. So I can answer that from the other side of what the other piece is happening. And if I come back to the health inequalities point, the data is already telling us, even if I come to the question of cardiac arrests, they are happening more in the deprived areas. That's where we need the community defibrillators to be. So if we are working with our charity partners to put where the defibrillators need to be, we're looking at how do we locate them. And all of that is harnessing the power of data that we've got in our systems, and how do we use that intelligence to guide our next steps rather than constantly just reacting to what's coming to the door next.
Yeah, Ali.
I'll keep it, shall I? Thank you. It's really good to see the strategy. A couple of points from me. The adult social care strategy for the North that's just about to emerge after the election period for consultation. When I was leading that work, and Sam will working very closely with Sam here, it was very clear that the demand into adult social care was high demand from EMAS as well in terms of safeguarding. So I suppose my point is how do we join these strategies up? So the models, there's a primary care model emerging, and we need to think that as we're delivering these, we've got to then, if you fast track forward 2 years, it might be that each of the local area partnerships knows its EMAS activity in terms of coming through. So where are these people living, the inequalities, and how that connects, because we're beginning to pick some of that work up from the local area partnerships. So that, I think, is the beauty of what the Health and Wellbeing Board can add to alignment of not just strategies, but how we do those integrated delivery models.
I think there's a huge opportunity for joining up and working together in this field. As you say, people don't always have to go to hospital. That's if you can treat them in their home, then that is super. I think certainly with the falls, we found that as well, that they don't always have to go to hospital and that they can be treated, lifted up in Sam's area. Sorry, Rafi.
Thank you. From a practical point of view, I can see the change that has happened with the EMAS team, because when I see an increase of 63% of non-conveyance, my heart gets a little bit shaken of they all come to general practice, but they are not. There are lots of referral going to community team, frailty team, ICT team, and so on. And also advice to stay at home. And we still have discussions at any time of the day, afternoon, and especially on a Friday afternoon to try and keep people at home. But yeah, there is, I haven't seen an increase impact into general practice. I've been working with the Federation more on understanding the numbers, and I wonder if you're liaising with them. So in general practice, I have the advantage of seeing what's the on-the-day demand, and I love numbers, so I looked from a different point of view, and I know what's the number per thousand population per week that has an impact on general practice. I got the same number that patients from practice is going to A&E, so I know that one. Missing is how many people come in to EMAS in a week, and I wonder if we can have a conversation outside. As I said, I'm working together with Federation on the day strategy. Yeah.
Thank you. Did you want to come back, Matt?
I was planning on combining a few points, if I could. I think if I can come back to the question of numbers, what we are trying to also strike a balance between with it being a regional service while also trying to manage a local relationship as well at the same point, and what's going to be the nuance. I haven't got a clear answer on that. We want to do it, but we're probably going to be limited by our capacity rather than the desire or the ambition. Now, at this point, the reason why it's two of us and not just one, because I will disappear into HQ tomorrow, but Mike will be the one who's the key part within the relationship, and we want to carry on, and we want to keep that link going. As a GP myself, I'm very mindful that the EMAS stack looks very close to what a general practice on-the-day demand can be like, and if there's any opportunity to harness that, we would want to be doing it. The question is going to be how. I also come to the point with regards to the social care strategy, and this is where I keep talking about that frailty number, that long-term conditions number, because we have to be honest with what is the right model for care that we need to have. EMAS model, if it changes, it does have an impact on everything else, and we need consistency in that. We need to be able to respond to that. I'll also come to the question of end of life. People are at that stage where we are not able to reverse everything, and we have to be open and honest about them, because at the end of the day, if they end up dying in a busy A&E corridor, is that really the right place? So what can we do to support them? And we need a planned approach to do it, rather than a reactive last-minute piecemeal. So any points to join that up at a strategic level as well, so that we can plan for the next few years or decades, that will be really key.
Sam?
Completely agree. So, and actually listening to all the conversations, and I think just about every piece on the agenda has had some linkage to the direction of travel. And you're right, whatever we do as individual organisations will always have a knock-on impact for other parts of the system. But where I feel that we've started to mature is we have a conversation about those potential knock-on impacts. And actually, some of the knock-on impacts that you're describing in your strategy, from a social care point of view, I think, well, actually, that's really, really positive. So Councillor Mercer made the comment about falls. So if you have a non-injurious faller, and I can send my reablement team to pick them up and give them some reablement intervention, we don't convey them to hospital. They don't have a long length of stay. They keep the acutes clear. They don't decompensate. I don't end up putting in a package of care. And lo and behold, more important than any of that, it's better for the person. So I just think we've got so much opportunity. We just need to harness that and bring it together to make sure that we, and obviously there's so much going on and you can see it in pockets, but it's all of those interdependencies. So the Mick talking about, primarily the rapid response pulling off the stack, but actually I pull directly off of the rapid response teams when they don't need that level of clinical input, because then I get the chance to re-able them. And it's that system approach that gets us those good outcomes. I get very excited about this stuff, but yeah, it's good.
Yeah, Mick.
Thank you, Sam. Yeah, and I fully agree with you. And I agree with the gentleman's comment at the end previously about relationships are better now with the system, and all this is built on relationships. I've got such a good relationship with the system, I can pick up the phone to Sam, we've got this, what do you think, and that sort of thing. 2-3 years ago, we probably weren't there. And this is what this is going to be built on, is that network and relationship within Northamptonshire. Not to wait for a committee to come and make a decision, be able to do things in real time and make a difference.
Yeah, I think that's where the Health and Wellbeing Board comes in. It's building those relationships, making those connections so that you can pick up the phone. You don't have to wait till the next Health and Wellbeing Board to see. So, any other comments from anyone? Okay. Well, thank you very much for that. And board is asked to note the strategy. And thank you for coming. Next, go on to North Place Board. And I'd like to ask Ali to present the report.
Thank you. My very last delivery of my report. Thank you. I apologise, I was a bit speechless earlier on, which is again rare for me, so I hadn't quite expected that. So thank you very much, and I am going to miss you all and wish you good luck in place. So final paper from me. So we have launched phase 4 of the improved functioning of the local area partnerships and place-based partnerships. I think I briefed the board when we sat last time. This is very live now, and I think I've referred all the way through the meeting that if we don't mature the local area partnership functions and really make them fit for purpose, they won't be able to help and support the delivery of some of the strategies, and actually all the strategies that are beginning to come through the Health and Wellbeing Board. So this is being embraced, and just to summarise what phase 4 for the local area partnerships means, so section 4.2, we're sort of reconnecting them with data. So we have the census data and the local area profiles about the inequalities and demography of the population. We're now bringing different sets of data in there. So you can see in Appendix A that we're bringing data on community transport. So each of the local area partnerships will have a community transport plan, which will involve voluntary sector, it involves non-emergency EMAS, it involves KGH within that, and our voluntary sector drivers. So how do you bring your partners together, bring the data together, cut it at local area partnership level, and then work with communities? That is a very different way of maturing the development of local area partnerships. So this is an example. But we need to make sure that we have the right people in the room and that it isn't just networking and the collaboration, that it's a little bit more formality around data, proper engagement with and co-production with the residents. And our local area partnerships in the north have been very much about the bottom-up identification of priorities, which we will maintain that function, but they will also now be receiving an ask top-down. For example, smoking, tobacco, we talked about Corby, and what's coming through from the active work that Chris talked about. So we need to make sure that we're driving that evolution. So that launch of that phase 4, we now need to make sure that we nurture it and make sure it's embedded. The next, 4.4, the next area of development in phase 4 were the previous community wellbeing forums, which are now the place-based partnerships. Now, this is a big step for Place to make. It's the start of a conversation. In your paper, you have got Appendix A, which is the King's Fund analysis of integrated care systems and what they're recommending as future functions for place-based partnerships. So this is a very different model. So it's not just an engagement model. It means we've got an opportunity to pool resources, to have more joint planning together, to use our collaborative relationships and really start to drive some of the agenda that we need to do, because we all know that the resources are not plentiful, so how do we use them differently? So it sets a different authority and accountability proposition for the place-based partnerships. So this is very early days, but it has been launched, and there was a workshop in this room with the Place Board partners for the North and all relevant stakeholders. So this room was full. We had conversations about how we would do this. So this is a proper co-production piece of work with partners. And there is a proposition from that workshop going to the Place Board on Tuesday afternoon next week, and that will be the first sighting of it. And that will then, there'll be an ask of the Place Board leads to take that into their organisations to contribute to that, because we need to do this correctly. We need to do what's right for Northamptonshire, and we need to bring partners with us. So that's quite a shift. I think it will be a phased approach. We won't be able to do that straight away, but we need to reset the function of the place-based partnerships to allow us to do that. The final point in my paper is what's already been covered, Jane, in your the action log, and that was around the ask from the chair to around support Northamptonshire, and that's been resolved now. So I thank all partners for contributing to that. But I would say it took a long time to do that. It was painful to do it. So we need to think about my point earlier on about the place-based partnership. So how can we start to get our function more developed within place, so that that becomes slicker, and that we do more of that, and we work collaboratively, and we make sure we're investing in the right way together. The point that we've had as a thread all the way through the meeting around proactive care, actually the last point, section within the paper, I presented in the last board meeting a variation of all the service offers and the complexity of our preventative service offers, from the Ageing Well through to Sport Northants. We've got social prescribers across all our services. So that programme, and I've been chairing that transformation board, is now live. So we have got the right leaders across the system together to look at, not looking at the service offer, but what do we want to do in the preventative space in line with Live Your Best Life, and the proactive care space for the future, which links back a little bit to what EMAS were just saying around their strategy. But this isn't just the top-end, complex, long-term conditions. This is the universal preventative offer of preventing collectively social isolation, improving health and well-being, and it's a very different model. It's difficult to get into that space, but the leads are committed to doing that. And in my absence, I've asked Jane and the DPHs to stay close to that piece of work and to chair that meeting. So it's a pan-county piece of work. It's not just in Northamptonshire. It will go down to place once we've started to really work through what we want to do about this. So hopefully that's another one of my legacies I can leave within Northamptonshire. At that point, Chair, I'll just happy to take any questions.
Turned off. Any questions or comments from anybody? Well, there's a huge amount of work been done, and it's evolved over time, I think, because seeing how it started off and then felt that it needed to change slightly, and moved it, to I think now a working model. So it's obviously we'll see how it works out in the future, but I'm certain it's going to bring people together more. Jane.
Just a quick one, Ali, about proactive care, because what I would say is I think for this board, proactive care is really pivotal.
Yes.
Because it's linked into so many ambitions of this board and so many ambitions of many strategies that we've got across the system. And really happy to be moving into that space that you have so expertly crafted around proactive care. But I would also, Chair, like to suggest that we bring an item to this board in the future about where we are with proactive care. And for anybody who's slightly confused by that term, that includes all of that work that we've called many things, haven't we? So social prescribing, for example, sits in that space. But what we need is an offer that is about that universal offer. It's about those people who need a little bit more support and those people who need a little bit more support than that. And how do we work together as a system? Because by doing that, we can do things like hopefully take pressure off general practice, take pressure off adult social care, policing and various other parts of the system. So to me, I think that is a really pivotal piece of work that we need to really grasp in the next 12 months.
Yes, I mean, that's a big piece of work that now it's got going with the Transformation Board. It's good. We'll have to be good to bring that back to see how that's gone. Okay, Naomi.
Alias, this is your last meeting. I suppose I want to thank you again. Others have done so. But I want to know what you think are the 3 things that are the most important achievements of the last couple of years, and what are your worries as you leave us? What would you say to us are the most important things we have to think about? I know it's in the paper, but there's a huge amount of detail. I want the sort of big picture.
Okay. So if we take ourselves back to 2.5 years ago, and we sat in this Health and Wellbeing Board, we didn't even know what a local area partnership was. We didn't understand how we segmented our population, our data. We do now, and also I think probably the thing I'm most proud of for everybody and all organisations in this room is everybody's referring to lapse. Every organisation understands there's an opportunity with lapse, and there's a spectrum of understanding of that. So that's a huge step forward, and that's not the same for every integrated care system nationally, because we have, our ICS has taken on board those general wider determinants of health and embraced it within the Live Your Best Life strategy. So if we some ICSs don't have that Live Your Best Life strategy either. So we've got to keep referring to that. Going back to Jane's point about proactive care, this is going to be difficult. That piece of work is absolutely vital for this board to grasp and oversee and support those leaders to do it. It will mean looking at resources in a different way, working in a different way, and actually probably is going to be the most powerful thing to deliver our Live Your Best Life strategy. So I would also say that I've led on the housing strategy and the adult social care strategy, not just place. And what's beginning to emerge is that the new strategies or the revised strategies for organisations have got place at the heart of them now. It's not just organisational strategies, they're recognising the population and the broader place agenda within the county. Actually, it's not just Northamptonshire. My word of lessons learned, just the final thing, Naomi, and I'd expect you to ask me a question like this. You always ask me a question like this, is that we sit in this public setting. This is difficult, what we're all doing, and there's a maturity of the system that it can break or bond relationships when it gets difficult. So my ask would be that when it gets difficult, that we keep that collaboration and not just sitting in this room, but that we help the people out there in our workforce to do that, and to, as leaders, to go board to floor, so make sure we're out there talking and walking the change and be an ambassador for the change. Those things have helped leading from the front in the development of place.
Thank you. And it's quite a deep question for Ali as her final meeting. So thank you very much. Okay, but it's I think a very good legacy that you've left there, and I hope you'll keep in touch and see how it goes.
I certainly will, and thank you all for your support. And I've got a couple of weeks left, so you'll still see me.
Okay, right. So we were just asked to note the progression of that, and we move on to the Better Care Fund update. And I'd like to hand over to Sam to tell us about that.
Fabulous, thank you. So, Better Care Fund update. I bring one every Health and Wellbeing Board. This is the end of year performance update. So this will close down, if you like, the 22-20.
No, it's 23. Is it 22-23?
Yes.
Yeah.
So I just thought I'd put a little bit of context around. So there is a couple of appendices within the pack. And the crux of the report is to go through where did we land. So we set ourselves some targets and metrics in which we would benchmark ourselves. I've done the quarterly updates to the Health and Wellbeing Board, but I did want to just take us back to actually what does that mean. So the Better Care Fund has been crucial in supporting people to live healthy, independent and dignified lives through joining up health, social care in houses and wrapping them seamlessly round the person. And that really kind of feels like it's been the theme of today in everything that we've talked about. It all kind of connects. So it was like you're all setting me up to kind of get to this point. It was really positive. And the BCF set out some core objectives, and that was to enable people to stay well, safe, independent and at home for longer, and to provide people with the right care at the right place at the right time. So in order to set the year 22-23 forward, there were a number of things that we were required as a system. So I'm kind of the person who leads on the BCF, but it's actually a real collaboration of partners. So we're required to submit a planning template. So I've just done the planning template for this year, and that's been submitted to NHS England, and at the next board I'll be walking you through what that template looks like for this year. Part of that template looks at the income that we get as a Northamptonshire system, the schemes that we want to use it against, meeting the outcomes of the BCF and the conditions that they've set. More recently, it's also asked us to look at things like our anticipated demand for certain things. So we look at demand for hospital discharges across various pathways, and we have to look at the capacity that we're going to have to meet that demand. And we have to reflect on that to make sure that as a system we feel a level of assurance that we've got enough capacity to meet the demand. And then there's also at that time that was submitted and is in there as an appendices, the narrative plans. So the BCF planning templates are quite large, unwieldy spreadsheets, but the narrative plan really brings to life how we're going to deliver on those ambitions and how we're going to improve on those metrics and those targets. So I put all of that in there for context. I wasn't planning to go through it because, as I said, it will be when I present next time. The interesting thing about this year's BCF was the 22-23 and the 23-24 was part of a 2-year plan. So actually what they did was, rather than giving us the BCF allocation and letting us go year by year, there was a bit of more of a forward thinking, so some money to enable us to plan how we really wanted to use that to get some better outcomes. So there was also the additionality of the discharge grant, which came into allocations, one that went into our colleagues in the ICB and one that came directly into adult social care. But we have to jointly agree on how we're going to use that discharge grant to meet the grant conditions, but also to get the best outcomes for people. So all of that, but that element of discharge funding was noticeably different for this period of the plan. So the metrics that we're asked to measure against and that I bring back on a quarterly basis are avoidable admissions to hospital, how can we, the amount of people that are admitted to hospital due to a fall, the rate of people that are discharged to their usual place of residence. So if they came in from their home address, that they returned to their home address, and if they came in from a care home or a supported living environment, that they returned to where they came from. Looking at the rates of permanent admissions to residential and nursing homes, and how effective our reablement interventions are. So they're the key metrics that we report on. So a broad overview of our performance for this year. So under the avoidable admissions, we set a target of about 250 per 100,000 of the population. And as you can see by the quarterly returns, broadly we were on track. I am going to put a caveat on quarter 4, and that's that we do see a lag in some of the data and some of them flag up a U code. So that looks like we've smashed it out the park in the last quarter. I would say there's a level of hesitancy and we might see the data catch up. But actually what's supported in the delivery of this particular metric goes back to some of the things that we've been doing around proactive care. So all of the things that Ali and other people have talked about is actually supporting the delivery of reducing those avoidable admissions, particularly for our over 65 cohort. And what was really interesting was when I was talking to colleagues to pull this together, we've maintained our performance and our target, but on the backdrop of a 2% increase in that level of population, which is really positive. The next metric that we looked at is the people aged 65 plus that return to their usual place of residence. So we had a plan, I've got a typo here, our plan was actually to maintain our current performance from last year at 91.2%, and we came in with an actual performance level of about 94% of people returned to their usual place of residence after a hospital admission. And I think some of the things that we've delivered through BCF schemes that have really supported that is significant amount of work with partners in Kettering General Hospital and NHFT on really streamlining our transfer of care hubs within the acute, so making sure we don't do assessments in hospital, that causes an unnecessary delay, but really making sure that we're making the most independent decisions for people and that we then have the capacity that we need. And I think I've brought some evidence of some of the dashboards that we use to show that our pathways are effective. So actually our pathway 1 discharges, meaning people go home, that they go home quickly. And I think by using that transfer of care hub to get the right outcome for people is speeding them up and evidently having an impact on them being able to go home. Interestingly, within that one, it also has enabled us. So if you look at some of the schemes and expenditure, we've invested in things like Tavida, which is an external reablement partner where we've purchased an extra 966 hours of reablement capacity for people, which is really positive because it means we've increased that capacity on Pathway 1, enabling us to get more people home first time, but also increasing our Pathway 2 capacity, Pathway 2 being where people need rehab or reablement in a bedded environment, to make sure that we've got sufficient capacity there, which again gives them that second opportunity to return home. So that's quite a positive metric. The next one is our falls data, so looking at emergency admissions to hospital due to falls. And again, we're broadly in line with the target that we set and our performance against that target. And again, that really links us into some of the presentations from our EMAS colleagues, because actually some of the work around see and treat, hear and treat, the work pulling off the stack, and then indeed our own reablement services that are offering, for non-injurious falls to be able to go out and support those people with the use of things like razor chairs to keep them at home, is really showing that that again is having a benefit within that metric that's demonstrated in the BCF there. So this one I'm quite proud of, and I'm not ashamed to say that. So for people whose permanent admissions to residential and nursing placements, and colleagues that have sat on the board for a little while will remember that we were a bit of an outlier for this, and our performance really wasn't great. And actually, one of the things that we've invested in as a system is Thackley Green, which is our specialist care centre. And we've seen, so we set a plan of 564 discharges into residential and nursing placements, and our actuals have come in at 452.7. So you can see we're actually well below what we anticipated, and that is because we've got that additional capacity within that rehab and respite centre, which means that we're giving people the second opportunity to return home with proactive therapy input, which means that they are returning home, whereas before, when we were reliant on external market capacity, where potentially there wasn't the ability to have proactive therapy and respite, people were much more likely to stay in those care home facilities. So that is having a really positive impact on that metric. And then the last one is our effectiveness of reablement. So we talked about having more capacity, and we talked about more people going through Pathway 1 and home. But actually, how do we know that we're getting good outcomes for people? So the effectiveness of reablement, we look at how many of those individuals that went out with that reablement service remained at home 91 days after they were discharged. And actually, we had a plan of 87.4, we came in with an actual of 87. Our measure is based on Q4, but actually if you go back and look over the quarters of the reports, so at quarter 1 we were at 87%, quarter 2 we jumped up to 84%, in quarter 3 we actually hit 90% of people going home. So actually we saw a slight surge in the amount of people coming through and a slight drop in our effectiveness in the last quarter. But I think when you reflect that over the totality of the year, really positive outcomes for people. So, in a nutshell, that's our BCF end of year performance report. As I said, I will bring to the next board this year's planning template so that we can talk about how we're going to manage things moving forward. But I'm more than happy to take any questions or comments.
Okay, any comments or questions from anyone? It's some of the stats there are excellent, and I think it just feeds into all the things that were being said before, especially about the proactive care, the EMAS strategy, etc. It's all sort of seems to suddenly be all the pieces of jigsaw just slotting together. So that's really good, and certainly things like the razor chairs, which you probably may know that team were put forward as to get an award for the HSJ, and sadly didn't actually win an award, but certainly being put forward for that was an honour, and all the stats around the Thackley Green and the help that's given us to keep people out of care or out of hospital. And there's so much going to go on with AI in the future, and some of the looking after people in their own home, the doc at home, etc. That there's a lot of positives there. So yeah, Prince.
Yeah.
Sorry,
thank you. Just a quick one on that. I'm aware that that reablement is very, very important, and also the fact that maybe the correlation between the stars within the hospitals, whether that is also reflected in terms of how many people get back, after the 91 days and things like that. Within the VCSE, are there other partners within that actually working in the same area, and whether you getting stars, or the stars you gave is just specifically to your area or within the VCSE as a whole?
So the majority of the stats, so it's system level data, but the reablement episodes that we count will be our own internal reablement function, and then our reablement partners, so the schemes that we've routed through the BCF. What the demand and capacity modelling shows, so that does cover capacity that has been commissioned from the third voluntary sector, so that does show in some of that capacity, because obviously some of the hospitals have contracts with varying agencies, I won't name names because that wouldn't be fair, that deliver and support people to return home that aren't necessarily a statutory service. And actually, we would be right to argue that we should be building the resilience of those services to deliver that on our behalf, and us to focus on, the statutory elements, which is where we're bringing in people like Support Northants into the adult social care teams to build that level of resilience, and more importantly, to help us deal with the rise in demand.
Yeah. Yes.
Yeah, I think it's really great to hear this work's going on, and patients are being kept out of hospital when they're being discharged. My only question is, and this is certainly slightly anecdotal, is like a tube of toothpaste. If you squeeze in one place, it bulges out somewhere else. And we've had practices, shall we say, saying that these patients are being put back in the community in certain homes, and suddenly increases an unfunded pathway into the GP practices, because they're going into homes where practices are covering them, but they're not the standard type of patient, in the fact that they turn over far more quickly, and it's causing, shall we say, some disquiet amongst my members, and I just wonder if there's a way around this.
So I completely agree and acknowledge that that can be a problem, and it is a problem. It should be a reducing problem. So it's born from what we term as spot purchasing. So where we would buy a single bed in a residential home or a nursing home, and those individuals, those homes are covered. Where we've invested in block capacity, so Thackley Green, we actually have purchased enhanced GP support for those individuals, acknowledging that that would be too burdensome for any local practice. So when we're utilising the 51 beds that are in Thackley, we're not utilising 51 spot beds within the community. But I'm not saying that the practice of spot purchasing has stopped completely, because there are certain limitations on what Thackley can manage. It's not a nursing home, so actually some of the nursing provision does go out to spot provision.
Fair enough. It's just like I say, at the moment, with general workload, at anything that's extra, shall we say, reaching a point where it's the straw that's starting to break the camel's back. Yeah. And like I say, we're all for supporting our secondary care colleagues, but not at the expense of primary care.
Yeah, no, absolutely. And I think it's something, I mean, we're an outlier, aren't we, in North Northants for our population growth, particularly in our 65. So I completely appreciate where you're coming from.
Fair enough. Thank you.
Okay. Raf.
Yeah, of course I need to raise it as well, isn't it? Because the general practice is always the missing elements in the Better Care Fund. I raised a million times. What gets funded is waiting the last minute when winter monies come and few crumble comes in, and then we mobilize within sometime 24 hours. So that is your purge. You know, winter is coming, and I can tell you it's coming again this year, hopefully, you know. And yeah, you never know. There will be a point when, you know, we'll go. So, you know, and it's easy, as I said, you know, numbers are simple. You just purchase extra, you know, appointments, extra capacity. Every time you commissions a nursing home that is not Thackley for end-of-life pathways with that super turnaround, you know that is a GP behind it. So they're quantifiable, and it is just disheartening that we never features in there.
It does go. So I think potentially the issue is not a Better Care Fund issue, but a system awareness issue of how actually, so it goes back to that, you know, the interdependence of our system, where do the pressures come out? So I think it is an urgent care-based discussion, because you're right, sometimes we don't see primary care as involved in those discussions as we could do. So it's something that I or Mick could potentially take back to Coos to feedback for discussion.
I think it comes down to what Colin said. If you squeeze the toothpaste in one place, it squirts out somewhere else. And I think we'll have to be aware of that. Naomi?
Yeah, I mean, really encouraging report, and lovely to see good data. I suppose Colin's point is really, maybe we need an agenda item on primary care, in particular GPs, that will give us some data on what the knock-on effects are and how we manage that, because it will always be the case, and we need to make sure that the system is smooth. And so perhaps that's an agenda item for the future.
Yes, certainly. I think that's a very good point. Okay. Ali?
Just to give general practitioner colleagues some assurance, the emerging primary care strategies linking to the proactive care work. So we're completely embracing the potential new models that might need to be in place. It all connects, doesn't it? But we're all talking about connecting. We're not necessarily doing it yet, which is probably why we're having the conversation.
Yeah. Okay. Right, I can't see any other hands. So thank you very much for your contributions. And the board are asked to approve the Better Care Fund end-of-year performance template as submitted to submit to NHSE. Everyone happy with that? Okay. Well, thank you very much, Sam, for that. It's a very interesting report. And I think with that, that's the end of the meeting. I don't think we have any urgent items. So I'd like to thank you for your attendance, and see you again next time. Apart from Ali, of course, so farewell.